Hello and welcome to Checking the Vitals, a podcast powered by Specialty Care. I'm Todd Schlosser, and joining me today is Greg Mork, the Director of Clinical Perfusion at Rush University Medical Center. In this conversation, we discuss how he, quote-unquote, backed into his job as a perfusionist, how the training for perfusionists has changed over the years, and he also shares a very incredible personal story that left us both in tears. Enjoy the conversation. Well, Greg, thank you so much for joining us here on Checking the Vitals. I really appreciate your time this morning. I like to start out with a very similar question to most of our guests, and that is simply, what was it that made you want to pursue out or seek out a career in healthcare?
Well, Todd, when I first began college, my goal was to become a physical therapist.
Okay.
So I had started off taking all the physiology, kinesiology, a number of the different courses I needed to take for that point. And what I was beginning to find out is, especially after my second year at college, I found out that I needed a lot more experience in those fields to even be considered for the School of Physical Therapy.
Okay.
So what I ended up doing at that point was, believe it or not, change my major. It was a major career change for me at that point. And
Sure.
I ended up in business, but ultimately I ended up pursuing a math degree of all things.
Oh, okay.
And what had happened is my sister was a cardiovascular nurse. And this is back when the educational programs for perfusion were really just starting out.
Sure.
So for the most part, everybody was kind of, even though they were in a school, it was more or less on the job training with some didactic instruction. So my sister had told me that she's a cardiac scrub nurse for open heart surgery. She had told me that they were starting this program at Mount Sinai Hospital in Chicago for pump techs. Believe it or not, that's what they called us back then.
Wow. Okay.
And I said, you know what? I'm really close to getting my math degree. I had no idea what I was going to do at that point. So what I ended up doing is leaving my fourth year of school, right near it was the second semester, the spring semester, to start perfusion school. And from that point, fortunately, I had enough physiology and enough sciences that gave me a decent base for everything. But I honestly ended up in this field purely by accident. And I can tell you, it's probably the best thing I ever did.
Yeah, that's amazing. But back when you were in perfusion school, and I only know this because I know one of the two titles that you have is very associated with a now perfusion school. So what was that training like when you went through it? I do want to focus on what it is today, but what was it like when you were doing it, trying to finish up your math degree and then switching back then?
My training virtually it exists of two lectures, one on acid base and one on perfusion adequacy. And really, I just sat next to a perfusionist and I was told to pay attention to what's going on. Believe it or not, the first time I was in the OR, the first case I watched, and this is when I was considering going into the school, the first case I watched, I was put in one of these observation rooms up like in Grey's Anatomy, where you have the window and you look down on the surgery that's going on. I was put up there at 7 a.m, and the case went for ever and ever and ever and ever. And finally it's 4 or 5 o'clock in the afternoon.
Oh, wow.
And here I haven't gone to the bathroom all day long and I'm ready to bust.
Yeah.
And at this point I see all this equipment moving in and out of the room. And I had no clue what was going on. But finally, pretty much everybody left the room, even the anesthesiologist. The patient's still laying on the bed and they're putting these big stitches in his chest. And ironically, yeah, you're exactly right. The patient passed away. I had no clue, but that was the first case I saw.
Oh, wow.
And I've always been a very mechanically oriented person. I work on cars, boats, bikes, you name it. I love doing that kind of thing. And I truly believe that those type of things lend itself well to perfusion skills. But in a million years, I would have never thought that I would have gone into a field where the first patient I watched having perfusion or open heart surgery would have passed away. But I was eye-opening, and this is back in 77.
Okay.
And the success rate of open heart surgery back then is not what it is now. Now, rarely do you ever see somebody left in the OR.
Yeah.
But back then, unfortunately, because the techniques were different, a lot of things were different. Yeah.
Yeah. Techniques and technologies. I mean, things have grown a lot in the past. Well, since 77. I mean, that's what, 40, 50 years of experience in that field. So I'd imagine that surgery's gotten better. Systems have gotten better, techniques have gotten better. So all of that leads to better outcomes. And hopefully most people, I'm sure now, avoid that sort of most negative outcome.
Oh, absolutely. And one of the other things I'd like to say is once I did graduate from, believe it or not, my schooling I was more self-taught. I had good instructors, or I should say good people guiding me and good mentors while I was going through this stage of my life. And they were great, knowledgeable, lots of experience and a lot of practical experience. However, I graduated from the training program, and then I went to work at University of Illinois Hospital. And the way it used to work at that medical center, University of Illinois is on a medical center campus, and there's a VA hospital, a county hospital, and a state hospital, all within walking distance. Oh, wow. And the whole idea was that it was going to be this campus that would service all patients of all backgrounds. So the way I got started in pediatric surgery, I was hired by Cook County Hospital. Oh, okay. And it turned out that but we worked at all three hospitals equally. I was hired there, and the more senior person was on vacation, and there happened to be a day when there was a pediatric case at Cook County, an adult at the VA, an adult at U of I, and they said, "Greg, you're the Cook County employee. You got to go do the PEDS case." Well, I had never seen a PEDS case before in my life. And
now you're going to have to go pump it that day.
That's how I started.
Wow.
And
okay.
I read the books.
I'm sure.
I had the Clark and Reed right by my side, and I got through the case fine. But and this is the point. Education now is so much more fulfilling, and the information we give these students is so, adequate for what they're going to need to do once they get out. But most of the people that went through training when I did, we really didn't get that luxury. We had to learn on our own, and we had to learn quick.
It sounds a lot like trial by fire, which you do learn a lot very quickly, but that is very nerve-wracking and very difficult to get through, I think.
Well, I always tell the students and perfusionists, I said, the worst scenario you could have is having somebody who has no idea how much trouble they're in. And that's always the most scary thing, because they don't know what's going wrong. And I may have been that person back then. Yeah. And I hope not. I hope that I was vigilant and all the cases I did fine. But it just was a different educational process back then. And I'm glad I'm still involved in the educational side of this, because I can see how much better it is for the students. But it was an interesting start. And so most of the people who got into the profession around the same time that I did, we all backed into it. We didn't go to high school thinking that we wanted to be a perfusionist, because who knew even what perfusion was?
Yeah, you were pump techs back then.
We were pump techs back then. And even now, I still have to, if I go to update my passport, they'll say, "Oh, you're a perfusionist." I go, "No." It's like I need a cue card to explain what it is. "Oh, you're a doctor?" "No." "Oh, you're an anesthesiologist?" "No, I'm a perfusionist." And we go into the whole thing. And it's pretty interesting. But now people are starting to pick up a little bit about what we do. We're getting a little bit more exposure. There's still only 5,000 of us approximately in North America. So, I mean, if you look at our campus, we probably have more than 5,000 nurses just on that campus.
Oh, yeah.
So you compare that to 5,000 perfusionists across the country, and we're like a pinhead.
Oh, yeah. You guys are such a specialized job that there isn't a need for 100,000 perfusionists in the US. I mean, and don't get me wrong, I know there's a need for more than 5,000, but because you're so specialized and so focused on what you guys do, that you don't need to have as many perfusionists it would take to make that job sort of a household name. I did once hear a perfusionist when they were trying to explain what they do, and someone was saying, "Oh, you're a surgeon? No. Oh, you're an anesthesiologist? No." He said, but I play golf with those people. That was sort of his, but like we all worked together. I thought that was a very funny anecdote.
Yeah, it's changed quite a bit, and it's all for the better.
When I talk to a lot of perfusionists, especially the ones that are established, they all have stories like yours. And when I talk to sort of a younger generation, people who are just coming out of perfusion school, a lot of them are saying either, my dad or my mom was a surgeon or worked in the OR and either was a perfusionist or told me to go into it. Or so like, it seems like more people are figuring out about it, and the younger generation has a more direct path to it than I think an older generation did. But for a lot of the same reason you're talking about right now.
There's an interesting point to that. We get a lot of students who apply for the school.
Yeah.
And we do a lot of interviews, and we do our best to canvass all those applications to make sure all these people really want to be into the field, really understand what it is. But I'll tell you, we still get a number of people who have they'll sit at that interview or and they have no idea what perfusion really is. And obviously, we try to weed those people out as quick as we can.
Sure, yeah.
Because they're, a lot. I think with Google and the internet, I mean, people are Googling salaries and are Googling professions. They said, "Geez, this is a good paying profession. I want to be in it," but they have no idea, truly, what they're getting into with some of this stuff. So it's and even with that process in place, still a lot of students get through, and then once they get their first job, they go, "Geez, I didn't realize I had to be on call 24/7. I didn't realize I'd have to work 24 hours or more than 12 hours. I want to go home at 4:00 every day." And that's all. It's just hard to get that into some of the people now.
And you don't really want to invest, from an education standpoint, the time in a student to become a perfusionist that's going to do it for 3 years and stop, right?
Right. That's always a hard thing. But the reality is there are some people who go into perfusion and they use it as a stepping stone. And it's not a large percentage, but it's small, and they'll go on to become cardiac surgeons.
Sure. Yeah.
And I think that's great. I think that's, you're making yourself better. You're furthering your education. I mean, I would never consider being a cardiac surgeon. I love perfusion. Yeah. And fortunately I do, because some of the things that we've had to go through in the profession over the years, and the cases and the hardships, and walking out the door at Christmas morning when you got an emergency case and your kids are sitting there saying, "Where's Daddy going?" So these are all the things you just learn to live, and learning to live with being on call. I mean, God, I've been on call forever. And fortunately
since 77, it sounds like.
Fortunately now I don't carry a pager. I'm smart enough to have all my pages transferred over to my phone. So that was the best thing that ever happened.
Yeah. So it's all consolidated into one device.
Yeah. You don't have this goofy pager on your hip. And I can remember jumping into the water with this thing on my hip. I go, "Oh boy, it's not going to work now." Yeah,
no, it's not. So you finished your perfusion program, for lack of a better term. How long was that you were in, quote unquote, training? Was it even called training? What was that program length?
Well, I received a diploma, and it was, according to the records, a 1-year training program.
Okay.
And really, as I said before, that consisted of a couple lectures, and I really just sat next to a bunch of senior perfusionists and watched them do cases. And then I was actually offered a position at the place where I trained.
Okay.
I turned that down because I wanted to go. I ended up going to work at University of Illinois at that point. But I received a diploma. There was no degree at the time. And at this time, you needed a high school degree, bachelor's degrees, or none of this stuff even existed in perfusion back then.
Okay.
So, and I graduated perfusion school. I didn't even have a bachelor's degree at the time. I went back and finished it later.
Yeah, you were so close when you went in.
Yeah, well, I did change gears a little bit, because I finished up my degree in allied health management and education, which was a really good degree to finish it up in, based on everything going on.
Sure, absolutely.
But it was a lot different, and actually, somewhere in I think it's the 80s is when the ACPE and KHIP, they started accrediting perfusion schools.
Sure.
And my school was around even before that. My school was accredited by the American Board of Cardiovascular Perfusion, which long since got out of the business.
Yeah. Okay. So when did you start pumping cases sort of on your own at the University of Illinois or that hospital system?
I finished up in 1978.
Okay.
And I was hired in, I believe it was January. And I was pumping cases pretty much the second week I was out of school. And like I said, I'm very fortunate because the perfusionists that I worked with were very active in AMSECT. They were very active in education. And I had tremendous role models that whole time. So I think, I owe a lot of what I do to those people who kind of brought me up into the profession. But they were very good about sitting with me and helping me through cases. And back when we started, cases were simpler. The patients were nowhere near as sick as they are now. Because now patients with, let's say, coronary artery disease or valvular disease, they get treated in the cath lab, and they get pushed way out in the line of treatment, and they get to the point where by the time they're actually considered for surgery, they're far more sick than they were when we used to get these patients back in the 70s and 80s. So it's just a completely different population. I mean, a good percent of our patients now are renal failure. I mean, we never saw that back in the late 70s, early 80s. So it was a lot different. But my mentors were extremely supportive, and they were really great people to have around when I was learning to do what I do. But I was pushed out pretty quick,
out of that nest, and you had to sort of learn how to fly on your own.
And there was a time when I was in the OR, and I was by myself, and the senior perfusionist was on the phone somewhere, which he did quite a bit. He was a great guy, but he was on the phone a lot, and he always had other angles working. So the surgeon said something, and I didn't understand what he said. And here I'm sitting in the back studying for my boards, and what he said to me was, he said, "Spin them," and I didn't know what that meant. Right. So then he turns around about 2 or 3 minutes later and says, "What's your flow?" I said, "I'm not flowing anything." And then, of course, he said, "Get Mike in the room and get my mentor in the room." Yeah. And spin them meant go on bypass. Yeah. I did not know that. But boy, I was surprised. But, these are all learning experiences that we go through. And I'm sure that specific terminology, spin them, is just something that doctor said. If you were in it with another surgeon, they may have said a different sort of colloquialism for it, or, so you've got to learn that with every new team you get on, I'd imagine. Without a doubt. And that's one of the challenges we have as perfusion educators now. Some perfusion educators will educate their students how they were taught. Yeah. Or all the mannerisms or clever little words that are used, and they'll teach them that way. What we try to do is say, here are all the things that you're going to come across. It may not be done this way. It may not be done that way. And I guarantee it's going to be different no matter where you go. So what we try to do is give them the basics. And then once they get out, they're going to be able to navigate all those tricky little sayings that people use and all the different mannerisms that the surgeons tend to have. I will tell you, though, the surgeons over the years, there have been some really tough guys to work with, but they're all getting to be puppy dogs now. You hear horror stories about stuff like that. Oh, there are. But I've never met a surgeon that I feel like would act that way in the OR, although I've never actually been in the OR in that setting, right? When I'm there, it's to, talk to people or whatever. I've never been actually in a surgery. It really goes across all the professions because things are different now. Yeah. And not only, there's arrogant surgeons, there's arrogant perfusionists too. Arrogant nurses. Sure. I mean, it's not just surgeons, but anesthesiologists. And there were some really tough people to work with. And I'm saying that very delicately. Let me ask this, though. So you start pumping cases late 70s, early 80s. Was the perfusion shortage that is going on now that we've talked about before, was that going on even back then, or were most places pretty staffed up? No, places were pretty well staffed up. But the first wave of perfusion shortages came, I'd say, in the early 80s.
Okay.
Well, so I was out for a little bit before I really didn't know whether there was a shortage or not. All I knew was the salaries seemed to be increasing pretty quickly.
Yeah.
And I've been born and raised in the Chicago area, and it was easy for me to get a job in Chicago. There was a time when that was not the case, but certainly in the mid 80s, that's when things started to tighten up the first time around, and there was a bit of a shortage of us.
Okay.
And it was to all our benefits because obviously our salaries went up, but staffing was a little bit different at the time, and things were just a little different back then. It was somewhere in the 90s, mid 90s. I think there was a lot of perfusionists because at one point, keep in mind, I believe there were 26 schools of perfusion at one point. Now we're down to 18.
Yeah.
And a lot of that is because a lot of little private hospitals that had a school like where I went couldn't really support a school. Now the schools are all affiliated with universities because they have the facilities and they have the resources to teach students the way they need to be taught. Yeah. So we went down, a lot of schools dropped out, and that's when the next shortage started to happen. And it was great for us perfusionists because the salaries were going up. But the trouble was we were stuck at hospitals and not being able to get help. Yeah. So in my mind, when the shortages happen, your paycheck is sort of the only benefit that you get from the shortage, because the work-life balance stuff goes out the window because less staff means you're working more hours. Like you said, you were always on call, missing Christmas some years. That sort of stuff gets worse as salaries get better because they're trying to combat this shortage, right? And they're trying to hold on to good perfusionists. Right. But the thing that you always have to keep in mind, and yes, the salaries went up, but we looked at the number of hours we were putting in every week, and all of a sudden you were working 1.5 jobs. Yeah, and you were working a lot. So yeah, the salaries went up, but they had to because we were working quite a bit more. And there was also a differentiation between how perfusionists were paid. Some were salaried and some were hourly. And I've always been salaried throughout my whole career, so it's never bothered me. But a lot of the hourly people said, you know what? When I'm sitting there at 2 a.m. doing an emergency case, I feel good that I'm getting, this bonus pay at the end of the week. Sure. Yeah. And I could completely understand that, but I've never been on that system since I've been working. So yeah, I've always been salaried. I've always just accepted it and realized, well, it's just part of the job. Yeah. Cost to be in this line of work, right? It is. Yeah. It's a unpredictable field. You end up doing cases sometimes on Saturdays and Sundays. Yeah. And they may not necessarily be emergency cases. They may be emergency out of convenience for whomever wanted to schedule a case. And you could complain about that till you're blue in the face and it's not going to get you anywhere. You just kind of accept it and move on. And of course, they're going to schedule those kind of cases when you have a wedding to go to that day or whatever. Of course. And you just have to take a deep breath and keep in mind that we're all there for patient safety and patient care. And it doesn't do anybody any good for us to come in there and complain about how we don't want to be there on a beautiful sunny day on a Sunday afternoon. You just go with it at that point. Absolutely. So I do know, because we talked about it a little bit before we started recording, that you got into working on the education side of it. I think you said it was in 93, although correct me if I'm wrong. Was that at Rush that you started working with the education side of perfusion? Well, at the time I was still at University of Illinois, and I became the chief perfusionist at U of I in the early 80s. Okay. And my supervisor, who was formerly at University of Illinois, he left, I believe this was in 89 or 90, somewhere in there. And he went to Rush, and his whole goal, he became the chief perfusionist at Rush. Okay. And his whole role was to start a perfusion school at Rush. And he did get all the paperwork in, and his first class went through in 1992. Oh, okay. Now, at U of I, we were asked early on whether we wanted to be a clinical rotation site for the school. And U of I was the first clinical rotation site for the Rush perfusion program. And the trouble we had was between all the lawyers and all the contracts and all the liabilities that went back and forth, it took 8 to 9 months for all of that to finally get resolved. And so we missed the first class. And then we became a clinical site the second year, which was 93.
Okay.
And my whole time at U of I, we were a site ever since then.
Yeah.
And it's been great.
Yeah, absolutely. So I'd like to talk about, since you have a long history, both in perfusion, but also on the education side, what are some of the biggest things you've seen change from late 70s when you started as far as education goes to where we are now with perfusion education?
Well, the biggest change has been the amount of information and the amount of experiences we expose the students to now. And possibly one of the biggest developments in perfusion education, as well as every other arm of education, is simulation.
Yeah.
Over the last 7 to 8 years, simulation has entered cardiovascular perfusion, and it's been just an amazing tool. All those things that I had to practice on a live patient or learn how to do on a live patient, we can simulate every bit of that on a simulator.
Yeah.
And we can create a high stressful situation for the students, or a low stressful, whatever we want to create, whatever experience we want to create, emergency situations, equipment failure, we can do that all with a simulator. Now, of course, a simulator is a simulator, and you always know there's not a patient connected to the other side. But I believe the biggest thing that the simulation has done is created a certain degree of muscle memory, and dexterity with the perfusionist, and they walk into these programs and they are far better prepared to do what they're going to have to do, even though they don't know what they're walking into on their first rotation, because we let them know it's going to be different. They may do things completely different than you ever saw in school, but at least they've seen and they have an idea what the program is or what the techniques are going to be, and they know, more importantly, how many things can go wrong.
Yeah. I once heard someone talk about, it was perfusion simulation, and they said it was really all about providing the students a safe place to fail. And I thought that was it hit me in a very profound way, because I can't think of many more high stakes operations than stopping the heart to perform surgery on it. And that's not the time you want to fail. So simulation giving you the safe place to fail and learn and practice and just get those, what my high school coaches would call repetitions on the ball, right? To get actually good at the job before you're asked to do it alone.
Well, in addition to the students, 2 years ago, we started running the cardiovascular residents through the simulator.
Oh, okay.
And boy, do we have fun doing that. Because they sit down at the pump and we throw everything at them but the kitchen sink. And they get a whole different perspective. Because there are surgeons that are very well versed in perfusion, and there's some that are not. Some surgeons just expect the perfusionist to provide all the technical support. But at least from my perspective, surgeons that have an understanding and a feel for what goes on behind the console are just great to work with, because they understand the challenges we have, and they're not always the same as what they have. So when we were able to put these residents, we put them on a simulator, and of course we had fun with them.
Yeah.
We would give them every problematic scenario, poor venous return, air in a line, air everywhere, and they would just get flustered. But at the end of the day, we got them to the point where they had an appreciation of things that went on with the heart-lung machine that they never had before. And a surgeon can't teach them that, an anesthesiologist can't teach them that, or a professor. But once they sit behind the pump, they had a great appreciation for things that we do. And I will tell you, as instructors, we had a blast.
Well, I'm sure you had a blast.
We did. And
I'm sure they did.
they were sweating a little bit, because, some people they refuse to acknowledge the fact that they may not know something. You always run across people like that.
Yes, absolutely.
But we've had good luck, and all of our residents have been very modest and humble, and they admit they did not know what was coming at them.
Yeah.
So that was the fun part.
I'm sure. Yeah. Well, and sort of like you were talking about before, the times I've gotten in the most trouble in my life have been times where I was like, oh, I know how to do this, not knowing how to do something. And then that coming back to haunt me. So I definitely understand why that would be fun for you as someone who knows how to do the job.
Yeah.
Teaching those who think they know how to do it. Yeah.
It was entertaining. That's for sure. But I think it was beneficial because those residents are going to go on and they're going to have an appreciation for what goes on with the perfusionist. And I think the more people that understand what we do, the better off we're going to be. I mean, this includes nurses and anesthesiologists and the surgeons and everybody else who happens to be in the room at any given time. I think the more they know about what we do and how they can help us if for some reason we get in trouble, the better off we'll all be.
Yeah, absolutely. I do think, well, and I'm sure that the amount of lectures that these perfusion students get has gone up. I have to imagine that you have a lot more didactic training in perfusion school now than you did when, say, you went through it in the 70s.
Oh, absolutely. Now there's a core curriculum that each school, this is developed by the ACPE, and there are certain things that are expected to be taught in every school, and that doesn't change for any school. And that's the good thing with compliance and how the schools have all kind of come into line with teaching similar things. We're responsible for teaching everything on the core curriculum.
Yeah.
And it's completely different. And as an example, the core curriculum is changing a little bit as we go. With COVID, the amount of ECMO usage that has across the country is it's just gone through the roof.
Yeah.
So now what we do with our students at Rush is we send them on ECMO rotations, and they're seeing far more ECMO than they would have seen 2 years ago.
And is that just simply because there are more cases to observe now?
There are more cases to observe, and the ECMO has really grown and been validated as a good treatment therapy.
Yeah.
There was a time when ECMO was almost a death sentence for an adult. In the pediatric population, it was a little different because the selection process was different. But in adults, there was a long time where when patients were put on ECMO, it was not expected that they're going to survive. Well, now patients survive. Patients are doing well. And the techniques have gotten so much better. So now it's a viable technique. It's something that perfusionists need to know and need to understand. And to be completely honest, it is at the core of what we do. I mean, it's oxygenation, circulation, and it is at the core of what perfusionists do. So I think it's, the school's responsibility to give the students now, especially since they're going to run into it, a good background on ECMO therapy.
Yeah, because I'm sure that they'll be expected to know it once they, leave school. I'm sure it comes up on the boards. I'd imagine. I don't know for sure, but I'm sure it comes up on the board certifications you guys have to go through to get accredited, right?
Yeah, it does. It absolutely is part of the boards. And even though ECMO, it depends on the hospital. Some ECMO programs are perfusion run, some are nurse run, some are respiratory therapy run, and the perfusionist may not have a direct contact with all those ECMO patients, but they will become involved at some point. It just depends on which hospital and what their structure is. At Rush, we have a lot of ECMO specialists, and the perfusionists are responsible for initiating ECMO and terminating ECMO.
Yeah.
So that's how it works there. So we have to know. And I think it's better for all these professions to work together, because there's value to having nurses on the ECMO team. There's value to respiratory therapists, and there's value for perfusionists. So I think it's a package deal, and it's really developed over the last 5 to 7 years. I mean, it's just exploded in viability.
Yeah. And I know for a fact, because we talked about this earlier as well, that you had some experiences with ECMO that.
One of the most impactful times of my career was we had a patient that was on ECMO for 8 months.
Yeah. And
this patient was clearly, several attempts were made to wean this patient from ECMO, and they all failed. And as it turned out, through his course of ECMO therapy, he had some lung issues that were not going to get better. All the ECMO months in the world were not going to make this patient's lungs heal themselves. And this is the unfortunate reality with ECMO. For the most part, we try to place ECMOs, or the surgeons and the therapists try to place patients on ECMO that are going to do well.
Yeah.
I mean, you want all these resources to go into something that is actually going to have a positive outcome in the end. Every so often, you're going to run into these patients where you just can't wean them from ECMO. So the options are either a lung transplant in this person's case, but he had cancer, so that wasn't going to happen.
Yeah.
So we got stuck between a rock and a hard place with this patient. And one of the things that I'm not sure everybody is truly understanding of is the hardship that's put on the families of these patients at times, because we had patients that were on ECMO for more than 8 months, and family members would be at the bedside every day. Now, that's very supportive, but you think about how that affects the family. I mean, the family, they probably couldn't work or couldn't do, there's a number of things that changes with them. And it's a real tough, it puts them in a real tough situation. Not to say that the therapy shouldn't be used, because you hope it always can be.
Absolutely.
But in this case, this patient was not going to wean successfully from ECMO. And he lived in an outside suburb about 90 miles away from Chicago. And the goal, if we could have transferred him to a medical center that provided ECMO support near his house, that would have been the perfect solution. Yeah. But as it was, the patient said, you know what, I don't want to be on ECMO anymore. He just didn't want it. And to be honest with you, I don't blame him, because it just put it. And I don't know if you've ever been a patient in the hospital, but as you're laying in the hospital, you see all these people visiting you, and it can be stressful. Yeah. And you see how it's disrupted their lives. So he was going through all these things. So after he made a request to the surgeons in the hospital that he wants to be at home, and he wants to be removed from bypass at home around his family. Mm-hmm. So after a ton of legal battles in the hospital, and believe me, when I heard this the first time around, I said, this is nuts. This is absolutely nuts. What kind of can of worms are we getting into if we terminate ECMO care in somebody's house? Does this mean everybody who's not going to want to come off or can't come off ECMO, we're going to have to go to their house? But this was a unique situation because he was out in the sticks. And so the final result was that the hospital agreed, and all the lawyers agreed, and all the surgeons agreed that we would transport this patient to his home. And we would go by, we had a couple ambulances, one ambulance with equipment, one ambulance with the patient. And I was with the patient because obviously I was running the ECMO circuit. Yeah. And when we got to the patient's house, they had a huge buffet set out. They put the bed in the middle, and they had a hospital bed in the middle of the great room. Yeah. Everybody was there. Yeah.
Yeah. It's, I understand the feeling there. I've, due to circumstances in my life, been present at something like that. And it is incredibly sad, but it's also an incredible gift that you gave that family and that patient.
But you know what? The family was great. They invited us they gave us food. Yeah. And once we got the patient settled in, all the grandkids were there. He was drinking beer. And of course, what happens when you drink a lot of beer? He had to use the bathroom. Yeah. He had to use the facilities. And, it's to be expected. I mean, the same thing happens to me if I drink a lot of beer. And it was, we would all leave the room while he did this and come back, but he had his grandkids playing on his lap and everything else. Yeah. And then what happened is things got quiet in the room because there were a lot of people, a lot of relatives. Things got pretty quiet in the room. And what I was not aware of is the timetable that they had set up for this whole thing. And that was a time when we were going to start weaning the patient off of ECMO. And they gave a lot of sedatives and a lot of other things. And it was a very, very, very touching situation, and very, it's something I disagreed with in the beginning, but I thought, geez, what a gift to give that family. Yeah. And everybody that was involved with that whole thing, because it was really a nice send off, call it what you want, But, the guy got, and they ordered food out. He got burritos and all kinds of other crazy things.
Yeah.
All the things he wasn't going to get in the hospital, he got there.
Yeah.
And there happened to be a bar right next door, and they're bringing in all this liquor, and they turned it into a party.
Yeah.
But at the time when it should have been solemn, it was.
Yeah.
And we discontinued support, and there was really no chance that he was going to wean off successfully. But he was made extremely comfortable, and all the support was there, and the family was extremely thankful. And to this day, I gave this presentation at one of our perfusion meetings.
Yeah.
And you could hear a pin drop.
Yeah, I'm sure.
So anyway, this is how much we as perfusionists really love what we do. And whenever we can impact a family like that, it's just tremendous.
Yeah. And like you said, it is a tremendous gift that you gave them. It is a very sad moment, and it's a moment they will always remember because of that. But I don't know of anyone who would say, yeah, I'd rather die alone in a hospital than surrounded by my family who are having a party around. Like, that sounds so much better to me.
It's completely understandable. And, in the ambulance ride out, it turns out the guy was a NASCAR fan, which I am as well.
Sure.
And we were talking all these NASCAR drivers and everything else. So it was a moment that I'll probably never duplicate, but I was glad I was able to be part of it. I'm not supporting the fact that everybody should be decannulated at home when they can't come off bypass. But I think there's always some unique situations where something like this is probably the best thing for everybody to do.
Yeah, I mean, you'll probably never do it again, but there's no way you'll ever forget it either.
Right. It was an unforgettable episode or moment in at least my life as a perfusionist.
Yeah, absolutely. I'm sure it had a profound impact on how you see things going forward too.
Oh, believe me.
Yeah.
It's just a compassion you have for families.
Yeah.
Especially when they have family members that are on ECMO that it just doesn't seem. I mean, we've had patients on ECMO for over a year.
Oh, wow.
And just imagine the impact that has on families. It's a tough one to deal with, I'm sure. So I'm always sensitive to that whenever I talk to the families, or, they always ask me, well, what would you do? I go, well, I mean, it's a tough situation. Everybody's individual. Everybody has their own ideas on what is the best thing to do.
Yeah. Yeah. A lot of that's, not to get too spiritual, a lot of that's tied up in belief, and you don't want to impose your beliefs on other people who have their own beliefs. It's end of life decisions are always very, very personal. And it sounds like that gentleman made that decision, and all you guys did was support it.
Right. So now that I've gotten through that story, I'm better.
Yeah.
It is always tough to tell.
Yeah, no, I'm sure. But I do appreciate you sharing that. And I'm sure that most perfusionists that have been established for a while have had experiences like that, cases that they will never forget because they had some emotional tie to it for whatever reason, whatever the scenario was. And I think that there is some value in sharing those stories.
Well, when I was a perfusionist just out of school in the first few years, I was in my 20s. All the patients were older than me. Yeah. There came a point when all of a sudden those patients were the same age as I was. And I'm not talking about 50s or 60s. I'm talking about a 30-year-old that has an ASD or a VSD, and you look at that patient on the table and they look completely healthy. They're doing this in the summer so they don't miss school or work or whatever it is that they're trying to do. Yeah. And it's a little bit of a reality check when that stuff starts happening, because we always expect the patients to look very sick on a table, but they don't always look that way.
Yeah. So I understand that when you were on the board of cardiovascular perfusion, you worked to make some changes while you were there that had an impact on, a large number of perfusionists. Can we talk about that some?
Perfusionists are required to do so many cases per year. And what would happen is that, let's say the number is 40. If that perfusionist didn't do 40 cases in that year for whatever the reason, because if you recall, there was a time when angioplasties first came into the picture and the caseload dropped. And then there were perfusionists at some hospitals that weren't able to get the number of cases they need to finish their, get their certification paperwork in. So what would happen is the old certification technique or old certification guidelines was that if you didn't do your 40 cases, let's say, then the following year you'd have to do those 40 cases plus the ones you didn't make up or didn't do the previous year.
Right.
And it got to a point where if you were in a program that you were struggling with getting cases, you're just circling the drain till you lose your certification. And then you lose it after so many, 3 years of that. And you have to take the exam over again. There's a lot of things, a lot of hoops you have to jump through to take.
Right.
And not just that instance. What changed my perspective on this was the board received an email from a young female perfusionist that was at New York Presbyterian Hospital out in New York.
Yeah.
And she brought up this scenario. What if I want to start a family and I want to have one child, another, and maybe another one, and they want to get their family built early. And as it turns out, it would be very difficult for that person if they wanted to have one child, then another, or even just two in a row. It became very difficult for them to maintain their certification, and they would have to make a choice. Yeah. They would either start a family, but risk losing their certificate, or probably risk losing their certification.
Yeah.
And that email really struck home with myself and some of the other board members that were on the board at the time. And we started looking at things. Well, having a family is just one aspect of it. Now you got medical leave. What if somebody gets sick and they can't perform their duties, or military leave? So what we did is kind of lumped it all into one group where it didn't matter, for whatever the reason is. If you have a valid reason for not being able to do cases for a period of time, you are allowed to. What happens is you keep your certification, but it's called conditional certification. And nobody knows what that is other than you and the American board. That's not something that gets advertised, or you don't have to change your initials at all. But what it did do is allowed people to not do the cases for a period of time. Or let's say somebody wanted to leave the field and go into sales and come back. It gave them the opportunity to do that. Yeah. And all that we required at that point was they keep up with their continuing education, which at the time, online education, it's an easy thing to do. You read articles, you can get all the professional education you need. And on top of that, what we required was that the perfusionists then would have a perfusionist at their hospital sign off on all their cases. So we thought, some people consider the American Board certification a competency, and it's not. It's just numbers, and it's things that we show that we've learned, and we can regurgitate on either an exam, or we can demonstrate it by doing all these cases. But that doesn't really demonstrate competency. And we thought the best people to evaluate this person's competency are his peers at his hospital. Yeah. So what we did is change the certification so that when that person came back, he or she didn't have to make up all these cases. All they had to do is perform a certain number of cases and have one of their peers sign off on those cases and attest to their competency, and that was it. And that has really saved lots and lots of certifications out there.
Oh, I'm sure it has. When did this happen? I feel like not enough people know that this is a thing right now.
You're right. This happened. I became the president of the American Board in 2010, and this really started in 2009. Okay. And one of the other board members, a former president, Linda Mangiero, who works for specialty care.
Oh yeah, I know Linda.
She is the one that really was kind of spearheading this in the beginning. And so when I became president, as a senior board member, you have the ability, what the rules are, how you can get things passed through.
Of course.
So the first year, what I did, and we had a lot of junior board members on the board at the time. The first year, I just presented the information of what we wanted to do. And I had no intention on wanting to pass it because I wanted it to parse through the board. And sometimes you pass rules and laws and requirements that have unintended consequences. Sure. So we wanted to make sure that was not going to happen with this. So we talked about it for about a year, and then finally it was the year before I left the board that we held the vote on it, and it passed. And it's the one thing that I can hang my head on as far as what I've done on the American board. But I did not do that alone. As I said, Linda Mangiero was a real strong factor in getting that done, and with her support and lots of other people's support, we were able to get past. So I really feel that it's saved a lot of people's careers. People can, leave the field for a year, 2 years, 3 years, and not worry about losing their certification, although they're still involved with continuing education and all these other things. So I think it's a good thing. But you're right. To this day, I still run across perfusionists who are afraid to be short cases 1 year, fearing that they're going to lose their certification. So, I don't know whether the American board has to do a better job of advertising. It's not really their responsibility to do that.
Right.
But at least my staff, when we have some staff members go to the instruction side, and they're not doing as many cases as they were before. So I would tell them, look, relax. You have an option here. Don't worry about doing these cases this year. You can always pick up with it next year. It's not going to be a problem. Yeah. And it takes a lot of stress off a lot of the things, especially for perfusion education, because one of the problems with perfusion educators, they don't have the time to get in the OR as much as they'd like to. So it allowed us to keep a lot more good people certified, and they're competent people. They're extremely competent. And I know that those that have taken advantage of it are very thankful for it.
Well, and the system in place now that you guys set up has a way to weed out people who are no longer competent, and they're, I'm sure they do get weeded out if they're no longer competent. Right. That system is already in place. Right.
And I truly believe that all certifications and licensures aside, I think it's your peers that you work with are the people and the surgeons and the anesthesiologists. Those Absolutely. Are the people that are ultimately going to be able to gauge your competency in doing what we do. And that's, I think, the appropriate place for those kind of things to happen.
Yeah, absolutely.
The way perfusion has changed from the time I got into it till today. And if there was not a year that went by that people were telling me perfusion's going to go away, perfusion's going to go away every year, angioplasties are going to destroy perfusion, TAVRs are going to destroy perfusion, you're not going to need the pump anymore. With each year that is going on, it turns out that the scope and the spectrum of things that perfusionists have at their fingertips to cover has just expanded tenfold. Yeah. So our school had some issues a few years back, and the dean wanted to close the school. They thought, nobody's going to go into perfusion anymore. And we had to tell them, no, that is not the case at all. And now they are so thankful for that, because we take 18 students each year. We have well over 100 applicants.
Yeah, you're turning a lot away, I'm sure.
And the difference in the caliber of the applicants now as what they were back when we were 4 or 5 students and getting maybe 10 applicants. I mean, we'd get people, bricklayers and every other field applying for the school. Now, sure, these kids are smart, and they're all top shelf academics, and they're really so. Perfusion is going to be around a long time, and we've seen it change a lot. And I believe me, I am the first one to admit that I don't know everything there is to know about perfusion. I mean, I learn things new every day.
Well, things change every day.
Oh, they do. So, and you know what? One of the surgeons once told me, he said, you know what? If you're doing things because it worked and that's the only reason you're doing them, that's really the wrong reason. He was a real proponent of evidence-based medicine, and we should always be getting better at what we do.
I would like to close with one final question, if that's all right. And that is simply to ask this, because I'm sure you deal with a lot of students every day. And I'm sure because you deal with a lot of students every day, some people who are considering going to perfusion school also get a hold of you and talk to you and ask you, why should I get into perfusion? So when people ask you that question, what is it that you tell them to try to sway them into a career in perfusion?
Well, there's obviously a certain stress level of the position that we hold in the operating room, and that is certainly not a reason to do anything. However, if these students are looking to really have an impact on a patient's life and patient care, and there is one point in the OR time, when the patient's in the operating room, that patient will be completely in the hands of the perfusionist.
Yeah.
In other words, the anesthesiologist will be out of the picture at this point once the patient's on bypass, because we're not only supporting the circulation, but the oxygenation. And then the surgeon is doing what he's doing he or she's doing up in his end of the field, and he's working on the heart. And if you want a very rewarding and ever-changing field, I mean, perfusion is such an exciting field to me. And I mean, as I said, I have a certain mechanical aptitude, and it just fits right into what we do. And I love working with the different equipment. I love working with the patients and the people in the room, and you're part of a cardiac team and a good OR team that you just can't beat it, because everybody's got the same goal, and it's all about patient safety and patient outcomes.
Yeah. I've never worked on an OR team, but I have worked on some teams that just knew what to do and how to fit into everyone else's job. And it makes for a wonderful work experience.
Well, there's another aspect to it too. When you work in a highly stressful situation, now perfusion teams are different. Now, if you're at a hospital that's got 4, 5, 6, maybe 7 or 8 perfusionists, you cannot help but become somehow personally involved with your fellow staff. I mean, it's just, you rely on one another. You go to their kids' weddings, you do all these things. You ultimately end up becoming really good friends with the people you work with, just because of the fact that you're working in some very stressful situations.
Yeah, it's like a foxhole mentality.
Yeah,
right?
it's exactly right. Now, it's a little different when you have a staff of 20 or 30.
Sure.
Of course, it's going to be a little bit more dilute, but you're still going to end up becoming very close, as I became very close to all the people I worked on the American board with.
Yeah,
AMSEC, and all my former staff members and that I've worked with. You just consider them friends, and I have perfusion friends that I will have till the day I go off into ECMO land or whatever, wherever we end up going as perfusionists. I'm not sure.
Well, thank you so much, Greg, for taking the time to be on Checking the Vitals with us. I really, really appreciate your time, and I honestly learned a lot. Thank you so much.
It was my pleasure. Thank you very much, Todd.
Thank you for listening to Checking the Vitals. If you enjoyed the content we provide, please leave us a 5-star rating and review. It really does help people find the show. And make sure you subscribe so you hear our interviews with healthcare innovators every Monday.